Hi, I'm Christie Cabral. I'm also in the Centre for Academic Primary Care in Bristol, and I'm here talking about the RuBICoN HIT today, which is really about thinking about respiratory infections in the community and in NHS and trying to generally reduce the burden of care. So I'm going to talk a little bit about our aims and a little bit about what we've done, and then I'm going to focus in on some of the academic research we've been doing and what we hope it's going to do in terms of informing our programme going forward. So the overall aim is to think about how can we do some prevention, reduce the number of respiratory tract infections out there in the community, particularly amongst children who are kind of a pool of infection for the rest of us, as anyone with kids will be well aware, to try and improve self-care strategies, including sort of pharmacy-led care, to think about improving, how can we improve the appropriateness, sorry about the terms, but it's quite difficult to define exactly, of healthcare use and antibiotic prescribing, and hospitalisation as well. So we've been doing a number of different things. There's a respiratory hot clinic. I am not going to attempt to talk about that. I don't know very much about it, I'm afraid. We do have some new parent advice sessions. This was a GP who, off her own initiative, had started trying to provide educational sessions for parents, and we've been working with her to see whether we can take and perhaps change a little bit what she's doing and take it out to a broader audience. Also, some work looking at how can we get a better way of collecting data on GP antibiotic prescribing as a way of helping them benchmark and understand, you know, what might be a safe level in terms of both avoiding hospital admissions and reducing antibiotic resistance in the community. And then we've been doing a number of research projects, closely related research projects, looking at the management of respiratory tract infections in children, generally younger children under 12. And that's what I'm going to really focus on today. So just very quickly, and apologies, I'm a researcher, I can't help myself talking about the methods. So this was a large 5-year programme grant for applied research. We had 5 work streams. We reviewed all of the existing quantitative and qualitative evidence that we thought was relevant to understanding how respiratory tract infections in children were managed. We did, actually I'm going to click on 3 qualitative studies, talk to parents. We did 2 different studies with parents, talking to them about what happened leading up to their decision to consult, what happened in consultations. We did a qualitative study talking to clinicians, so both GPs and nurse practitioners. And as I said, we reviewed everything. We then said, okay, we're missing a trick here. We need to do some additional research. You know, being researchers, more research is obviously needed. 5 years is not enough. And we went and did the Conquer Unpack studies, where we videoed consultations and then interviewed parents and clinicians about what was going on in that interaction itself. So just really quickly, some of our key findings, which we think it's really important that we found out stuff here that we really didn't know going into RuBICoN, stuff that is really going to help us understand what we can do that might make a difference and which is different to what's commonly being done at the moment. So we found from the parents' perspective, there's still a lot of uncertainty about when to consult, and that's not to do with you know, not knowing what they should consult for. It's more to do with the embodied experience of these symptoms and understanding what exactly a fever is and what kind of fever is the scary one and what kind of fever isn't the scary one. Sometimes all fevers are kind of scary. There's a lot of consulting just in case, so not seeking antibiotics, but seeking reassurance and information about what's going on, how should I manage this, particularly when children are very young. And the thing that made a difference to parents was having actionable information. Now, a lot of what we do at the moment is we tell parents and the public is that antibiotics don't work on viruses. Now, if you think about that, that is not a very useful piece of information unless you can tell which illnesses are caused by viruses. What parents really need are which symptoms can I probably safely manage at home, and which symptoms mean maybe I should get them checked out, and whether I should be going to the GP or the A&E, something that's a bit more precise. And something that's quite challenging, I think, quite scary for the health services and health practitioners to be very definitive about those. And often you find that the message that parents get is, well, come back if you're worried, which, you know, doesn't really help. In terms of antibiotic prescribing, we found a really widespread no treatment preference. Parents don't really like giving their children any kind of drugs. Parents did have antibiotic expectations, and these varied between populations. The highest antibiotic expectations we found were among populations of recent migrants who had experiences of healthcare systems where they habitually, the norm was to give out antibiotics for any kind of infection. And so it was really, in our system, where it isn't really the norm to give out antibiotics as commonly, but there isn't really much explanation given. So they would come and they'd come and see a doctor expecting to have the same experience that they'd had back at home, and the doctor would go, "You don't need antibiotics, go away." And they'd go, "But why? That doesn't make any sense to me." And the doctor didn't really have any way often of trying to explain that, because the doctor didn't really understand why on earth they might expect antibiotics for what to them was obviously a fairly well child. So what I'm saying is that clinical communication really matters in terms of managing the expectations. Although I would say that we looked really hard and didn't find much evidence that parental expectations for antibiotics was having a massive influence on actual prescribing. That it was much more to do with what was going on for the clinician. I'm going to come on to that. And the systematic reviews kind of bore out what we found, in that you can demonstrate that you can change parents' understanding and knowledge around antibiotics and whether or not they're needed, and that has no impact on actual prescribing rates. So you can see a change in knowledge and attitudes, but not prescribing rates in the quantitative literature. So the clinician perspective, that's just us showing off there. The key thing for them was the kind of prognostic uncertainty. And what they're doing is just in case prescriptions. So they're going, most of the children they see are they're happy not to prescribe for, and that's fine. And there's a tiny number of children they see that they go, "Oh, actually, we definitely need to do something about that." And then there's this minority of children where they kind of go, I'm not sure. I'm not sure that child isn't going to get worse. And so they end up prescribing just in case, because risking that child getting worse is risking a whole host of problems, both for the child and for themselves. And what clinicians really wanted was better evidence around how to identify the children that were most and least likely to benefit from antibiotics. So again, we don't know, it's the evidence linking whether or not it's bacterial, whether or not antibiotics will make a difference is quite difficult to come by, but you can look at whether or not children are what's associated with how likely they are to be hospitalised. And that seemed to be the most useful piece of information. That's something that we also worked on in the Target programme, but I'm not actually reporting on today. And they wanted additional training around, this was general practitioners who hadn't had an opportunity to work in secondary care paediatrics. They wanted more training around what do really sick children look like, so I can gauge the child who I see and where they're sort of falling on that spectrum. So we then started trying to think about, well, what can we do? Okay, I'm almost there. What can we do with some of this information? And we developed a number of resources which we are starting to disseminate out. We had a massive implementation day where we tried to share this with a whole bunch of CCGs from across the country. And I think Bristol CCG was one of the ones who came and took part in that. We developed, first of all, an animation based on the videos of the consultations, which was trying to be a training tool really for GPs to try and understand the parents' perspective and all the funny things that parents are worried about that clinicians might not really think about, and how they can try and address those, and to reassure them that there's a way of getting satisfied parents without prescribing antibiotics. And we developed a whole bunch of information resources for parents, a website and accompanying leaflets and posters to go in waiting rooms, which are kind of our starting point for what the parents' information needs, because a lot of the information for parents tends to be quite focused on what health services or practitioners think parents ought to know. So it has all of that information, but it does also focus a lot on the whole bunch of stuff that parents are quite worried about, like sleep disturbance and growth and how it's going to impact on that. And we're pulling all of that together and thinking about our strategy refresh and how we can use these resources to start trying to make a difference locally. And I think we're not doing questions now, so I can let off now. Thank you.